Değerli katılımcılar,
Esteemed participants, hello. In this session, we have two invaluable professors, and they will have a discussion, actually. Firstly, we will be hearing from Dost Öngür, and the topic will be Let's Continue Traditional Therapeutic Evidence-Based Medicine Improves the Health of Individual and Society and Avoids Unnecessary Medication and Therapy. So it will be in favor of traditional treatment, and Mesut Çetin will be advocating on better treatments are needed. In order to use the time effectively, I will be just passing the floor to Dost Öngür. The floor is yours. Hello, everyone. Today I am participating to the meeting from Boston, United States. And 4 years, when I had the opportunity, I was participating to the Congress, and hopefully for the next Congresses we will be all together face to face, and I do extend my best wishes to you. I've heard that the first couple of days of the Congress have been very fruitful, and as I've stated, hopefully for the next years we will be together. As I've stated, I was there in previous years. However, I believe 2 or 3 times that I've been involved in such discussions. However, this is my first time with Mesut Çetin. We were discussing with Serdar Dursun, who is participating from Canada. And it was quite enjoyable, as we have a very important and complex topic. We are able to have the discussion. It is not the case of being right or wrong. Having a different perspective is quite possible. And as Feza has stated, I will be trying to advocate in favor of evidence-based medicine, and in order to improve the public health, it is quite important to follow evidence-based. Surely it is not like if you're sick, if you have cold, do not drink herbal teas or do not cuddle with a blanket. It is not such an advocation, surely, but there are certain things that we can do which are quite affordable. However, in modern world, now there are certain waves standing right against scientific findings, and they do say, okay, medicine is not enough here, so we should follow these waves. What is the current situation? I will be talking about that, and after that I will be talking about alternative waves risks. Evidence-based medicine, we are saying conventional, however it is not conventional. Surely the tradition dates back to hundreds of years. In the light of empiric information, empiric data, and with daily life experiences, it is relatively near history. This derived from years of experiences, thousands of years contributed to that. Rome and ancient Greece. And on the other side, we have China, contributing to the field with 5,000 years. They've used empiric data, and they had the habit to adjust activities in certain activities. And in Islamic world, there's Ibn Sina, and they have the understanding that life has its own rules, and as humans we would like to have the life as we wish, but we need to identify the rules, the conditions of this world. So if we are aware of it, we may intervene, and upon intervention we may get certain results. In the Middle Ages, there was such an understanding, and after that we had the Enlightenment period leading to the scientific world. And then again, if we are talking about evidence-based medicine, there was a continuous fight against rumors and some beliefs which are not sound. For example, people have the belief that if you just step on the stone with a naked foot, you will get diarrhea. Everyone's family thinks it like that, but surely there could be certain relation. Maybe stepping a cold stone with a naked foot could cause certain problems. It may just hurt you. It may decrease your immune system's activity. However, it is not the direct cause of diarrhea. So this is just a simple example. There are numerous beliefs in such way, but in 19th century there was germ theory by German scientist Koch, and also Pasteur developed the vaccines, and then science just had its physical appearance all over the world. Then there was also the theory of diseases cell. It is not the whole body that gets ill, but it is the dysfunction of certain organs, especially. They just understood the pathology of vasculitis in the brain. And in 20th century, there was further improvements. Clinical studies, especially randomized clinical studies, have been started in the middle of 20th century. It became the dominant way of performing medicine. It is not a directive. It wasn't a directive. There wasn't a consensus. At one point, no one said, okay, this will be the way from now on. However, through the improvements and within the light of all information in the 21st century especially, you do see the dominant perspective of medicine in the newspapers, in daily life, in universities, and especially during the pandemic we have witnessed that very openly. Medicine's intervention could reorganize the society. Experts say, okay, we have examined that, we have checked the details, and we have learned all the truth, and now we should just close down the restaurants. No one should be allowed to the restaurants, or we have discovered the vaccines, the superiority of that is not debatable. Surely some people have debates over that. But 80% of the population have the understanding of, okay, if the experts say this, then there should be something that we should be relying on. And it is not like some experts who have some other agendas came together behind the closed doors and they are trying to change the course of the world. These science people contribute to the improvement of people's lives. And there are huge successes in this area with the contribution of these people. Yes, in one side we have the public health, and on the other side, evidence-based medicine always corrects itself and improves itself. I was in medical faculty in 90s, and for example, they were thinking that if there was a patient with heart attack, for example, you shouldn't run, you shouldn't eat that. I mean, you should just rest. But then after evidence-based intervention realized, and yes, we had the understanding of recommending rest to our patients. However, with the evidences, we have realized the actual situation. So there is no guarantee for these findings, but it was the logical option back in that time. Upon seeing the evidences, sometimes we just try to immediately make them physically active. And you do realize that it was the contrary. Physical exercise right after the attack is indeed a benefit for the patient. And we have realized this through the evidence-based medicine. It is always improving itself, questions itself. That's why we are relying on evidence. And in medical profession, we cannot say everything is based on evidences. There are certain studies, surely, but in a clinician's daily practice, for example, in just one day, how many of the interventions are based on evidence? We can say maybe 20, maybe 30% of them. For example, if there is an inflammatory disease, providing antibiotics or starting certain medication for COPD. Those are based on evidences. However, not every single hospitalization, not every single intervention that we perform based on evidence. However, there is a framework, and this framework is identified through the evidences. Whenever we need certain answers, evidence-based medicines methodology will lead you to truth. This is my opening speech. And when I saw the title, the topic of the session, you have to, it was inevitable not to think about pandemic. We experienced the same thing with this period, actually. If you take a broader look, evidence-based medicine can't know 100% of the subjects. We are all human beings. We may have certain mistakes, and in modern medicine, there could be mistakes, some wrongdoings. However, if you understand something prior to a disaster and make revisions over that, would be the right way. And for the pandemic, for example, an expert of infectious diseases published an article in New England Journal of Medicine in May regarding wearing masks. And it says it is a myth to wear masks. It doesn't protect you. It was exaggerated. You don't have to wear the mask. It is just a symbol. It will not protect you, but you feel safe somehow. But it was May. In May, no one was saying no one. Everyone was in lockdown, and the death rates were spiking, and everyone was commenting over the topics. Surely we couldn't say evidence-based medicine. And then the studies have started, and we have witnessed that in places where people wore masks, the infection rates have decreased, and slowly we have understood it. And it is not fair to say that gentleman was just saying some silly things. Of course, it wasn't. It wasn't. Back in that time, it was a comment, and the ways which are not based on evidence is quite questionable. From my perspective, then again, from United States, I can provide you an example. Cancer patients, oncology areas generally have sad endings. And it is quite painful. It causes lots of deaths. And it is one of the most common reasons of death. And in some subcultures of the United States, people say the doctors do not know what they do, and my mother was quite healthy. She was great, but then after the treatment she got bad, and the situation got worse. She died. But then with the improvement in technology and improvement in communication, these people started to came together, and they started to just flush their intestines with coffee, for example. They claim that coffee will benefit to the improvement from cancer. But this was just a myth. And yes, this is not evidence-based, and this is an alternative. If you can just deal with that. Okay, but in the society, they are trying to create some ways to do it. And then they claim, but you don't know the actual way to treat it, and you are trying certain things, and we are trying certain things. This is their claim, and you may have such interesting discussions. And they are questioning. We need to question the source of information. They do say, okay, I observed it I witnessed that from the first hand, for example, and they say, okay, they had this coffee flushing and it worked. He lived longer, so I need to do this for my mother. And if there's a wrong thing, for example, like masks, it is just symbolic. Don't worry about wearing masks, and the source is an expert, so the other people may aspire from this expert and develop their theories on the basis of that claim. However, historical background, the success, and also studies will lead us. On the other hand, because we have the risks for a cancer patient if they do not just have the cancer treatment at a hospital, and if they have coffee treatment by themselves. It is not taking herbal teas when you have cold. It is not the same case. And I will stop here. I will just pass it to Mesut. Indeed, you have talked briefly. You have informed us very nicely, starting from experience sharing, and this is not evidence-based, but you have talked about randomized control studies, what we have learned through the pandemic, and sometimes evidence-based medicine is questioned and improves itself. And yes, you also stated that we should evaluate the circumstances by asking, is everything evidence-based? But everything leads us to science. I'm just trying to summarize the things. The mistakes in modern medicine is not a sign for the mistakes in the practice, but it is an opportunity to improve the situation. And that coffee example was quite striking. So, as the last verse, evidence-based medicine has a history, and the others doesn't have a history. So we need to be careful about this new insights. And the floor is yours, Mesut. Thank you. Indeed, I couldn't participate to the Congress because I'm not feeling great, and it is an honor to be with Mesut in this session and have the moderation of Feyza. Thank you so much for your participation. And in many issues, I do agree with him. However, I would like to have some criticism over that. My perspective is like criticizing ourselves first. What can we do for preventive medicine? Is current treatment working really well, or is evidence-based medicine really based on evidences, or what is the situation? I'll be talking about that. Can we have the full screen of your presentation, if possible? Before starting your speech, is it possible to have a full screen of your slides? I'm so sorry to interrupt you, but we can see it, but we do not see it in full screen. After sharing your screen with your presentation, could you please just make it full screen? After sharing the screen, yes? Okay. Okay, I believe now it's working. I'm not seeing your slides. Okay, I will repeat that. Isn't it open? Okay, I can just see it. If we can have it in full screen, that will be perfect. I'm sorry we have lost time, but okay. I will take different perspectives for the discussion. In the world, mental health disorders are quite common, actually, and those are the statistics dates back a couple of years ago. Nearly 970 million people, 12% of them have certain mental disorders, and it is worse for young people, actually. 15% received mental health care in 1 year in the United States. And especially in the last years, from 2009 to 2017, major depression rates have increased hugely at the rate of 63% even. And these young people refers to healthcare services for treatment. And is it sufficient? Is the services sufficient? And when we check the financial cost, we do see that in 2019 in the United States there was a spending of $225 billion for mental health treatment. And per session, people pay $65 to $250 if they do not have any insurance. And meanwhile, a person with diabetes taking insulin can spend double, 54,800 to manage their condition. And Medicare has a 190-day lifetime limit on psychiatric inpatient care. There is a limitation. And what is the consequence of it? Suicides. If you check for dependencies, nearly 1 out of every 4 patients commit suicides. For major depressive, it is 1 out of 5. For schizophrenia, the percentage is 12%. This is quite sad. This is a public health problem. And when we check etiology of mental disorders and why evidence-based medicine is not enough, this is polygenic, and surely there's contribution of genes. However, environment and lifestyle are crucial points for their treatment. We need to just act on it. Policies should have an improvement for that. And when we examine the risk factors, some of the risk factors could be eliminated. We can prevent the onset of disease, and we can just improve the course of disease. For example, if it is substance abuse, for example, nutrition is hugely important. We can adjust this poor course, and the authorities should be dealing with that. The authorities are not healthcare authorities, but politics should be involved. And current trends in clinical psychiatry. Now, I believe for the clinical assessment, now in Turkey, clinicians spare only 15 minutes per patient. For example, for panic attack, if they have 5 signs out of 15, then you may have the diagnosis. And then they decide on the right antipsychotics and identify the right treatment way. So they do adjust the prescription in order to see the patient less frequent, because the burden is high. And we need to have the right treatment for the right patient. In order to do that, we should figure out the mechanisms of the diseases. Unfortunately, we have a lot to go to understand the exact mechanisms of these diseases, and we are somehow having trials on the drugs. And for the long term, there could be irreversible consequences on the organs, for example. For schizophrenia, for example, there are nearly more than 30 suggested drugs. And for example, clozapine is used, and 1 out of 3 of the patients do not respond to that. 1 out of 3 is in having a partial response, and 1 out of 3 have positive response to the treatment of antipsychotics. And when it comes to lithium, it is the same case for bipolar disorders, and it has full remission on 30% of the patients. Mood stabilizers are used for certain diagnoses, and if it is just lithium, and even in only 30% of these patients, they have thyroid disorders or some other problems in their renal functions, for example. So I don't want to make it difficult, make it longer for you, but the response rate for the major depression disorder is 30 to 40%. SSRIs are used, and mostly, and some other antidepressants are used, but with a 4 to 6 week delay, they do have a response. Imagine that there is a patient with a suicide ideation, or they attempted to commit suicide, but the response, the effect of the medication will start 4 or 6 weeks later, and it is dangerous somehow. We don't have the data to have exact predictions over the course for the treatment, and we are limited. And comorbidities are inevitables of psychiatry. I would like to provide you an example. For example, in bipolar disorder, we do see OCD comorbidity in 13% of the patients. We have provided SSRIs for the OCD patients, for example, but that could worsen mania, for example, and they could get manic. Omazepine, quetiapine, olanzapine, for example, does not have any impact on the improvement of OCD symptoms. So this is a challenging situation. And much of the psychiatry patients have comorbidities, and if we include physical problems as well, the number goes up. And we do see this empirically, and unfortunately, these empirical practices for comorbidities is not based on the evidences. Antipsychotic polymorphisy. This is quite common in schizophrenia, and APP seems to be prescribed for possibly more refractory patients. And for example, 70% of dopamine is blocked here. And with this hypothesis, second generation antipsychotics are combined for the treatment, and there is no side effect which is evidence-based. there could be some side effects, and unfortunately it is not possible to use certain drugs as a combination. And when we check the antidepressant combinations, in the first place it is SSRIs or SNRIs, and if there are resistant patients, then we start bupropion, mirtazapine. We were using those, however, we do not have strong evidences. And surely for the drug-drug interactions, there could be some other problems for the combination therapy. As I've stated, majority of them are off-label treatments, and some of them are not based on evidence. And we do see it in dementia, for example. For dementia patients, when we observe behavioral changes, we can initiate antipsychotic treatment, quetiapine, for example. It is quite common. And it could cause strokes, it could cause gaining weight, and it also increases the cost of treatment. As we have talked about quetiapine, I would like to criticize psychiatry. I would like to criticize ourselves. Quetiapine now represents 1/2 of all antipsychotic prescriptions all around. A new kind have occurred, and there is a dominance over academic psychiatry starting from 1950s. The basic idea is that the opposite of the drug action may be a clue to pathophysiology. For dopamine access theory, for example, if there is a psychotic disorder, and many are based on the antidopaminergic actions of most antipsychotic, antimanic drugs. But it is not a complete understanding. Many antidopaminergics could only have impact on 2 out of 3 of the cases, for example. Glutamate is important in certain cases, and there are some other factors. Even patient says, I have serotonin deficiency, and that's the reason I have this depression, or I have this anxiety, and they would like to start using drugs. And we have certain guidelines, surely, but to what extent they do, we can use them. As Dost has stated, evidence-based medicine is important, but I am trying to have a critical point of view. Is it 100% evidence-based? Let's assume that there's a new drug, and if we are just grouping them with these 2 very homogeneous groups, for example, we can compare 2 different action mechanisms and understand it. We need to have homogeneity. Because of the comorbidities, it is quite challenging to have homogeneity. I would like to elaborate the comorbidities. In bipolar disorder, for example, anxiety, post-traumatic stress disorder, OCD, or ADHD are quite common comorbidities, and vice versa. So we can't have homogeneous groups, and if we can't have the homogeneous groups, these patients are just excluded from the studies. This is an exclusion criteria to have a comorbidity, and this is the basis of these guidelines. I mean, these studies cannot have comorbidities, but we do see patients with comorbidities, and for that reason, there are certain critics against evidence-based medicine, against guidelines. Evidence-based medicine is like a cookbook. as this is based on RCTs, based on clinical trials. We can't have homogeneity in regard to comorbidities. Sometimes some universities do support the RCTs. However, mainly the financing of RCTs coming from the pharmaceutical companies, and they do finance the trials in which their own drugs are tested. So there is an asymmetry in accordance. This is the claim of certain people. Just to give an example to this, in a retrospective study, nearly 21,000 people are included to a bipolar patient cohort, and lithium and valproate were compared, and valproate use have increased 12 folds. In the first case, it was 6:1 in 1994, and in 2001 the ratio changed 1:2. And at least in relation to one very important outcome has occurred, attempted suicide or suicide has decreased, and lithium was just an orphan drug in that case. And the critics states, is it evidence-based medicine or is it patent-based medicine? That's the criticism. And also, generally those are short-term studies. For example, an antidepressant clinical effectiveness is measured with a trial lasting for 13 weeks. And after 13 weeks, you may just apply to FDA and get the approval from there. And this is another critic. Though majority of mental health problems may last for a lifetime, and there are other issues in regard to child and adolescent psychopharmacology practices. As you do know, in 2004, antidepressant use have been subjected to a black box warning in relation to the suicide attempts of adolescents. And in 2007, the warning was published for adults as well. And there were some publications showing the contrary of the situation, but it will be too long to go into details. And there is a large Australian study. Between 2008 to 2018, child, adolescent, and young adults were included to this study. Antidepressant use in between 0 to 27 years of age is 66%. Suicide rates have increased up to 49%. There was again a 98% increase in intentional poisonings with drugs among the age group of 5 to 19. These evidences show that antidepressants are not preventing suicide attempts, and FDA is right about this. So we do see the graphic here between the ages of 0 to 27. You can see the antidepressant use in blue, and the red shows us the suicide rates. As the antidepressant use increase, the rate of suicide increases. This is another study. Starting from 2011, for adolescent females, suicide rates are quite high. And these are the medications used, and you may see the fractions in accordance with the drugs. And for newer psychotropics, surely there are lots of side effects. I don't want to go into details. I believe you all know it. Even the patients, sexual side effects, weight impacts, etc. And they have, then again, have a certain attitude towards it. We need to overcome all these issues, and with antidepressants, there are minimal differences when we compare with placebos. Especially for younger ages, significance is quite low. And the superiority of antidepressants over one another is not quite clear. They have certain benefits of use. It is easy to use some of them, for example, and for that, in 2018, there is a publication in Lancet.
And here we see the amitriptyline, which has the best effects, and then we see other agents. And you see the acute phase use of almost 32 antipsychotics, and you can see clozapine there. But as you know, it's not easy to use because it has lots of side effects, and there are differences between those agents, and some of them have more side effects, and this is why they are not given frequently. And here, this is the Swedish study, and you can see that those who are over the age of 65 had a higher chance of fall injuries, and among persons with dementia, number of psychotropics was associated with increased risk of fall injuries again. You know Thomas Insel, and he was the NIMH president, director, and he said that I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders, and then when I look back on that, I realized that while I think I succeeded at getting lots of really cool papers published by cool scientists at fairly large costs, I think $20 billion was spent. And this is what proves our thesis. So today, with regards to the mental disorders, we can tell them they're a great public health problem affecting more than 1 billion people worldwide. Therefore, preventive measures and policies should be adopted at the level of governments rather than classical therapeutic approaches. Of course, prevention can be primordial, primary, secondary, or tertiary, and we generally focus on tertiary prevention. We try to give medication and correct the problem, but the other levels will be more and more effective since they will affect a large group of people. And here we have the health promotion and specific protection, such as health education, environmental modifications, nutritional interventions, lifestyle and behavior changes. WHO also recognizes the potential value of proactive or preventive strategies for tackling the global burden here. Inflammation is very important, and for many reasons you can have inflammation and it leads to many other diseases. This was published in Kaplan and Sadok's comprehensive textbook of psychiatry. This is the first thing you see, and as you can see here, stress is correlated with inflammation, depression, and tissue damage. And you can see that there is the ACTH, and we know that inflammation increases pro-inflammatory cytokines, chemokines, etc. And we know how important it is. Inflammation is very important in this respect, and Faiza also discussed this very clearly. So Inflammation is actually the main reason for many diseases. Therefore, stress and smoking and other factors can be corrected actually. Vitamin D deficiency, for instance, physical inactivity, etc. And we can correct these things, these factors, including sleep and the food we consume. And with regards to nutrition, you have three headlines on time. First of all, they said cholesterol was bad in 1984. Now they say that you should eat butter. There is still such a confusion. And gut bacteria are very important. There are some good bacteria and they have benefits for our body, and we can also educate the people about this, especially for them to eat healthy foods, because through GABA we can reduce stress and anxiety. Sugar consumption is too much in this modern life, and you can see the standard American diet, and it's abbreviated as SAD. And we have contemporary foods that affect the body, mind, and behaviors. We also have hypoglycemia, and this leads to mood lability and inattention, and can be misidentified as rapid cycling bipolar disorder or ADHD. You can see in this figure that after you eat short-chain carbohydrate, you will have a very high level of insulin secreted, and the blood glucose level increases. And in order to reduce this, it works hard and leads to hypoglycemia, and then it goes up again, and people feel hungry again and want to eat something else. So it's like a cycle, and once these stress hormones are released, because of anxiety or hypoglycemia, cognitive functions may be impaired. This is another argument, and as a result of this, you can gain weight, both in hypoglycemia or hyperglycemia. You may gain weight because of the fat storage. You can prevent this, for instance. This is something that can be corrected, like you fight smoking and other factors. Therefore, this publication of Lancet is very important. Nutritional medicine should now be considered as a mainstream element of health. And vagus nerve is very important, vagal nerve, and since 1980s it has been on the agenda, and we had vagal nerve stimulation for the depression. And this is very important because, as you know, from the intestines, from the abdominal organs and thoracic organs, there is an innervation, and it's very important with regards to anxiety, especially for panic disorders. You need to slow down your breathing, and your heart rate will also drop down. And in many diseases like anxiety or panic disorder, we see this effect because the partial oxygen pressure is reduced, and therefore the patient feels much more normal. And breathing techniques can be used, but as I told you, and as DOS told you, people can use these techniques, but they should be used carefully, because some people are not competent with it and they abuse these methods. But as psychiatrists, we should know about these techniques. Using the vagus, you can slow down your breathing, and GABAergic activity can be reduced. And in PTSD, you can reduce the overactivity of amygdala, and you can see the connections here. And here, as you can see, we take 12 breaths per minute, but if we take 5 breaths, the blood pressure goes down to 59 or 60. So if we keep our breath, it is 7.5 breaths per minute, and it's a bit faster, and it's like a panic state. This increases oxytocin and vasopressin, and this is something we use in therapies, and it will help you feel more empathetic to yourself. And physical activity reduces dementia by 38%, as mentioned by the previous speakers. There are lots of studies about this, especially about depression. Sedentary life increases obesity and also diabetes. Spending time in front of TV has a bad effect. There could be lots of preventive psychiatry approaches. Of course, medications will be used, but we should also pay attention to these factors, and they all have a role. In the polyclinics, we should tell about these to our patients. And with regards to the blood glucose level, fasting blood glucose, these are all the factors that should be checked. Postprandial blood sugar should be checked rather than fasting. And psychiatric disorders are a major public health concern affecting about 1 billion people worldwide. So what do we need? We need some other efforts that will have more effective, safer, and fast-acting psychotropic effects, because we know that almost 50% of the developed societies will meet the diagnosis for at least one psychiatric disorder in his or her lifetime. Therefore, with the MDMA, psychedelics may be used. Ketamine is already approved in 2019. It was approved, and especially for the treatment-resistant depression, it is used. And similarly, therefore, this is the case. So for the treatment-resistant depression, there are many factors. Suicide rate is increased by 7-fold, and ketamine is approved by FDA. It was approved in 2019, and esketamine is also approved. We know that esketamine works at the NMDA receptor. Therefore, we have some new horizons to go here. And with regards to the studies about esketamine or ketamine, we know that the mood is stabilized in a couple of hours, and this doesn't last, unfortunately, and it also has some side effects such as cystitis. Therefore, there are some adverse effects. But we know that esketamine has been approved by the FDA as a medication for treatment-resistant depression, and there are still ongoing studies about this. With regards to abuse or misuse, SAMHSA made a trial, and ketamine has a very low level of dependency, and painkillers, pain relievers are more problematic when it comes to misuse, stimulants, for instance, or benzodiazepines. As is told by Mihriban, those psychedelics should be taken in a very controlled manner, and these drugs are not given to the patients themselves. And it's only given on the days of therapy, on some days of the month, so it will not be very problematic. Therefore, we need some new initiatives here, and you can see many studies about them in ketamine, psilocybin, and ayahuasca is used for recurrent and treatment-resistant MDD. Therefore, some of these treatments can be temporary. The effects can be temporary. If you use some specific agents, for instance, MDMA, it's not problematic, they say. Mihriban or other researchers, and psilocybin is given for obsessive compulsive disorder. Ayahuasca is used for alcohol abuse, smoking cessation, and suicidality. And psilocybin and lysergic acid diethylamide is used for anxiety, depression, pain, and other issues. So I can easily tell you that we have more and more mental illnesses, so we should have some protective measures instead of reactive interventions. We should have more macro level interventions, because current therapies or treatments may lead to resistance in 20 or 30% of the patients. So this is not very small figure, because 20 or 30% of 1 billion people is quite high, and this is a challenge for both the patients and their families. So we need some new initiatives in this respect, and new psychiatric drugs do not come up every other day. So the government should be working here and should make some legislations for new treatments such as psychedelics assisted psychotherapies. Do no harm first. This is our motto, and our Congress will be here again next year between November 9 and 12. Thank you. Thank you very much for this presentation. You told that these psychiatric problems are very problematic for many people in the world. So I would like to thank you very much for your presentation. You talked about the new and promising treatment modalities. You underlined all the needs. I would like to ask our online participants to type their questions in the Q&A session. I would like to give the floor first to Dost, maybe, before taking the questions. It has been a very comprehensive presentation. We're trying to choose our side and focus on our arguments, but as you said, we should first criticize ourselves. And when we look at the current status of psychiatry, we can say that yes, it has advanced, but the needs are not met. So we need further major advancements. And you talked about psychedelics and drugs like ketamine, and now we're going towards the center from the periphery, and it will be an evidence-based approach, and we're waiting for it. It's a promising thing for the future. Thank you, Dost. I don't see a question typed in the Q&A section of the Zoom, but I would like to turn now to the audience in the hall. This was a thought-provoking session, and I took lots of notes. It was a very good and comprehensive review rather than a discussion. Can you hear me? Yes, we can hear you. I would like to thank you for your presentations, both of the speakers. I have a question about the placebo effect. we see the placebo effect in clinical practice, but I would like to ask a question about the ethical side of it, because placebo is used in trials as well, and sometimes you can use it in your clinical practice, and you have different type of drugs. For instance, you have the generics of it and you take one of it, but it doesn't make any effect on the patient, but the patient goes to another doctor and the doctor prescribes just a generic of the same agent. However, the patient has very good response, so it's apparent that this is placebo. And how can we use it in our clinical practice? Maybe it could be an approach because it's quite cheap. And
tabii kısaca aynen dediğiniz gibi plasebo insanlık tarihinin başından beri
placebo
kullandığı bir şey.
is something that is used by the physicians since the beginning of time, and you just feel the patient, make the patient feel
Enteresan çalışmalar var. Açık plasebo diye bir kavram var.
good
Hastaya söylüyorsun.
about the treatment, and there is the open placebo.
Yani şeker
And you tell the patients that there is the open placebo approach. You tell the patient about the placebo that you are giving to him or her, and even if you inform the patient that you have given him placebo, they can see an effect. As you said, it's cheap and it can be used. Why not? We can use it.
Dün çok güzel bir oturum vardı.
Yesterday we had a very good session about placebo and nocebo.
Plasebo mudur?
Is resistance a kind of placebo? This was one of the questions. Please
Hocam sizin eklemek istediğiniz bir şey
check the scientific program for this. Mesut, would you like to add any other comment? Those responded really well, and as a pharmacologist, you can give an answer too. But I can briefly say that
tedavi yöntemleri var ve
we have treatment modalities like homeopathy, and some of the patients make use of them, benefit from those approaches, and
hiç gündemde değil. Yani mesela en çok kullandıkları remedi dedikleri şeyler var. Yani
they have remedies
vitamini gibi bilmem ne gibi.
like vitamin B12, and they just give 5 drops of B12 and B12 vitamin, and tell the patients to drink that water, and it's kind of the self-healing you have. This is activated. The self-healing is being activated, and they heal themselves. And the same thing goes for acupuncture. All these things are virtual, I think, but it helps with the pain or psychosomatic diseases. Of course, placebo has an effect, but the problem is that in legal terms, if you have a patient who is suicidal, it will be problematic, especially for the clinical trials, I believe. You would probably provide some better information about this phase out.
Yine kendimi çok şanslı hissettim.
Yesterday, I attended one of the sessions, and I was a moderator. Yasin Hasan Balcı and others were there, and we discussed the need for biomarkers and resistance and etc.
Apayrı tartışmaya çok açık. Saatlerce
And we realized that there are lots of aspects of the issue, and we may discuss it for hours and hours, because the concept of placebo should be discussed in an ethical manner as well, from an ethical perspective as well, because you should decide which patients should take placebo and which patients should not, because some of them can be very severe patients. But when it comes to psychotherapy or the way that is presented are very important. We are human beings, but to keep it short, I can tell you that all these are important factors. Any other question from the audience?
Evet.
Sometimes they say that doctors themselves, their attitude are placebo.
Galiba bir şey var ama evet, ben müsaadenizi isteyeceğim.
I have to leave, unfortunately,
Bir görüşmeye katılmam gerekiyor. Ama yarım saat içinde zaten ya da 45 dakika içinde tekrar
but I will be back in a couple of minutes soon. Thank you very much. Thank you very much for your valuable time and your beautiful presentation. There is one question.
Sen çıkabilirsin. Yani bilmiyorum.
Thank you very much. I'm an adult psychiatry specialist. I'm working in Istanbul. My first question to Professor Dost. I would like to ask one question. In psychiatry, there are non-evidence-based methods that you have mentioned. What are they? For instance, maybe some methods of psychotherapy or phytotherapy that is very popular in Turkey in recent months, and complementary medicine or traditional medicine, ozone therapy, and other methods are being used by our colleagues. What is your take on this?
Bunların hepsi dahil. Hatta psikiyatri
All of these are included, and if we look back in history in psychiatry, we know that there were non-evidence-based approaches, and people already told them that they don't need evidence because they know what they were doing. But I think that patients come to me and families come to me and ask me and say that, okay, you can try it if it's not too expensive and if it will not have any severe side effects, you can try it. So I'm trying to find the balance here. For instance, acupuncture, it's very common and popular in the USA, and I don't think that it affects many people directly, but I would never say that you should never have acupuncture, because if you're not paying hundreds or thousands of dollars, you can try it. So there should be a balance there. Thank you very much. See you soon.
Hocam. Salonda başka soru var mı?
Any other question or comment for Dr. Mesut? Evet, ben Andy Greenshaw. Merhaba
Hi.
Mesut ve Feyza.
It's a very nice surprise.
Güzel bir sürpriz oldu.
I wonder if you can comment on the new data revolution in pulling all the evidence together, because we have focused on clinical trials for many years, and now we're moving into real world data analysis. And my question is, perhaps with some of the limitations based on group analysis, by moving towards precision health, we may get more value from some of the existing treatments that are available.
You mean special groups?
I just mean that when we look at the kinds of people that will respond, it's very difficult for a psychiatrist to take an individual patient and decide what treatment will be effective. But with the information from machine learning, we may be better able to make those choices.
Exactly. That's actually another issue. Are you receiving translation at the same time so I can continue in Turkish? Okay. Gerçekten çok önemli.
This is a very important point because
Tedavinin uygulandığı bireye ilişkin değişiklikler
there could be some changes in the treated individual, and all these factors affect the outcomes. As mentioned by Mesut, psychiatric diseases are actually somehow genetic diseases. He told that, and I can't agree more. I totally agree with you. Would you like to add anything, Mesut? Thank you. This is a good and important finding. Thank you very much, Andy.
Andy, I'm there with you. Hopefully next year we will be all together as usual.
I hope.
That's what I'm hoping. Evet, sanıyorum bu şahane
Okay, now
düşünmeye devam ederek
we will continue with all these important issues in our minds. These are really good topics. We can discuss it for hours and hours, but we have to continue. However, both speakers discussed the issue very well, and they were really thought-provoking. We will continue thinking about them. With your permission, I would like to declare this session closed, and I wish you all a successful Congress. Thank you.
18'de
Thank you. At 6 o'clock, we will have another session with Dost in Hall 4 about medical publications. And you know that he is the chief editor, and we will have this topic in the other hall. Thank you very much for your participation. Thank you very much for this reminder as well.